Hello everyone, welcome to our webinar, Fostering Mentorship to Advance Cancer Control, a case of promoting HPV vaccinations to parents and clinicians. My name is Mohammed Khalif. I'm the Senior Manager of Comprehensive Cancer Control at GW Cancer Center at the Institute for Patient-Centered Initiatives and Health Equity, formerly known as GW Cancer Institute. Our webinar features Kaneko Kashima, Senior Research Assistant for Comprehensive Cancer Control here at GW Cancer Center, and Riti Desai, a public health professional and a participant of the GW Cancer Center Mentorship Program. Before we dive in, I'd like to make a few housekeeping remarks. Although we would like you all to speak during the question and answer session at the end of the webinar, please mute your phones when not actively speaking in order to reduce background noise. Please do not put your phones on hold, as that may disturb the session with hold music or your organization's hold recording. In order to broaden the reach of useful information and lessons shared during this session, this webinar will be recorded. A link to today's presentation slides will be available for you is available for you in the resources section at the bottom of your screen, along with other related resources. So please feel free to download and follow along or share with your colleagues. Materials will be emailed to you after if you don't want to download right now. We are pleased to have two speakers for you today. Our first presenter, as I said, is Kaneko Kashima. She coordinates, provides, and evaluates technical assistance to comprehensive cancer control programs across the country, including managing community roundtables in 4 states to integrate cancer and chronic disease efforts, webinars, and the mentorship program. Kaneko is currently pursuing her master's in public health at GW's Milken Institute School of Public Health. Prior to joining the Comprehensive Cancer Control Project, she conducted intervention evaluation and exploratory research for multiple funders. Today, Kaneko will give an overview of the mentorship program. She will introduce our second speaker, Riti Desai, later. Without further ado, Kaneko, the floor is yours.
Thank you so much, Mohammed, and thank you all for being here for the webinar today. So just to give you a quick overview of what I'm going to be talking about, the learning objective is to identify a mentorship program inputs, activities, outputs, and outcomes. So in 2013, the GW Cancer Center won a 5-year cooperative agreement from CDC to provide intensive, tailored technical assistance to comprehensive cancer control programs to enhance their efforts. The GW Cancer Center completed a needs assessment in 2014 to guide project activities, which included an environmental scan of available technical assistance, key informant interviews, an aggregate look at past needs assessments from a number of organizations, and a literature review of online adult learning needs. We found a need for collaborating, enhancing connections, and building relationships. And a lot of people talked about wanting information on evidence-based practices and interventions and how to write communication plans. So the mentorship program was created to respond to these comp cancer needs. The needs assessment is actually accessible by clicking on one of the pods at the bottom of your screen as well if you want to access those. The mentorship program focused on communication planning, implementation, and evaluation, and was designed to support comprehensive cancer control program and coalition efforts. Using strategies to promote health is important, and we know from National Cancer Institute's Making Health Communication Programs work that communication alone can increase intended audience's knowledge of awareness on a health issue, prompt action, refute myths, and misconceptions, and more. And communication combined with other strategies can cause sustained change in which an individual adopts and maintains a new health behavior or an organization adopts and maintains a new policy direction, and overcome barriers or systematic problems such as insufficient access to care. The mentorship program was designed to support comprehensive cancer control program and coalition efforts by achieving the following broad objectives: increasing staff skills in core public health competency areas with a special focus on communication, facilitating completion of high-quality communication projects related to comprehensive cancer control communication or media plan objectives, encouraging the use of the spread of evidence-based practices, and providing opportunities for networking and collaborative learning. So here are the friendly faces of our mentors for the 2015-2016 cohort. Please note that these titles reflect the titles of mentors and mentees at the time of their participation in the program and may have changed since. Dr. Brad Love is an Associate Director for the Center for Health Communication at the University of Texas. Leslie Quiroz is a Communication Specialist at ICF International. And Dawn Swindle is the Health Education and Communications Director for the Cancer Control Section at the Indiana State Department of Health. So we thank them for their contribution. And here are our mentees for their cohort. Miriam Karanja is the Director of Programs for Arkansas Cancer Coalition. She worked on a communication campaign promoting colorectal cancer screening to African American males ages 50 and older in a rural county in Arkansas. Marissa Nelson is the Public Education and Outreach Coordinator at the Chronic Disease Prevention and Control Branch at Arkansas Department of Health. Marissa worked on a communication campaign promoting the MammaVan, which is a mobile mammography program in workplaces in Arkansas. And finally, Reedy Desai is the Coalition Coordinator for Cape Atlantic Coalition for Health. She worked on a communication campaign promoting HPV vaccination administration in health in New Jersey clinics, and we will hear from Reedy about her project later on. I will walk through the mentorship program's logic model, starting with inputs so you can get an in-depth idea of the structure and process. So the Cancer Center, GW Cancer Center Mentorship Program was a beneficiary of the very successful and established National Cancer Institute R2R's cooperative agreement supported program, including the process and the staff guidance that we received from them. We also have funding from CDC's cooperative agreement, including $500 that were awarded to each mentee to cover implementation costs. And we also had a one-time $1,000 for each mentor for their time and commitment. We also allocated $2,000 for mentors and mentees for in-person travel expenses. Other inputs included GW Cancer Center staff time, infrastructural resources such as a webinar platform and conference lines. And the GW Cancer Center also sent mentors and mentees reference materials and offered webcams if they needed them. Planning for the mentorship program included interviewing previous NCI R2R mentorship program staff, identifying areas of adaptation, and creating corresponding program descriptions. The mentorship program curriculum was also created based on research on public health competencies, health communication, and evidence-based practices. We also created a private portal using Google Sites. Here is a screen capture. This portal was designed for us to post programmatic announcements and for mentors and mentees to post their progress, documents, and questions. To recruit participants, we created an application process and selection criteria, put out a call for applicants in the spring of 2015, and reviewed all submissions. We also invited seasoned professionals to be mentors based on their experience in health communication, evidence-based approaches, and cancer control. We also administered the $500 for mentees to implement their communication projects and $1,000 for the mentors to secure their commitment and any other travel expenses and reference materials. We supported all monthly meetings, including setting the agenda and learning objectives, securing speakers, and providing virtual meeting platforms. There were 3 types of mentorship program meetings, and the first was internal meetings just with the mentors and mentees, and they used their webinar platforms using webcams. These meetings consisted of program updates from GW Cancer Center, project updates from mentors and mentees, and we did some troubleshooting. The second type of meeting was Ask the Expert sessions, which were dynamic, web-based, small group discussion forums led by experts on health communication, and we hosted those as well. And the third type of meeting was an internal meeting with just the mentors and mentees, but we had some guest speakers who are subject matter experts come and join us. GW Cancer Center also administered mid and post-program evaluation, the results of which I will cover shortly. The outputs of the mentorship program included the mentorship program portal, as mentioned previously, and the monthly meetings and seminars. Here's a more detailed look at the monthly meetings. We started in July with a quick kickoff meeting, and mentors and mentees used their webcams to meet one another and overview the program goals and objectives. Dawn, one of our mentors, led the meeting in August on evidence-based communication. September's meeting was an Ask the Expert session featuring speakers from Cancer Prevention and Control Research Network, or CPCRN, on how to use community assessment, evidence, and theory to inform cancer control approaches. October's meeting was an internal meeting with a guest speaker, again from CPCRN, on selecting and adapting evidence-based approaches. November's meeting was an Ask the Expert session with Dr. Turner from GW's School of Public Health on how to choose message appeals, tactics, and channels. Leslie, one of our mentors, led the December meeting on pre-testing messages. Come January, the following year, so in 2016, the meeting was a self-study session because of the holiday schedule, and so we assigned a recorded online meeting on building relationships with journalists and producing media-friendly materials. The February meeting was an Ask the Expert session with Karen Goldstein from Ogilvy Public Relations on kicking off and publicizing communication campaigns. March was another Ask the Expert session, this time with Dr. Hull from GW School of Public Health on implementing, evaluating, and improving communication campaigns. The May meeting featured a guest speaker, Alicia Smith from the Association of State and Territorial Health Officials, who talked about taking stock of potential partners and plan for dissemination. And finally, the June meeting was an internal meeting with the report outs of each mentee's health communication projects. Outputs also included in-person meetings and site visits. One mentee decided to visit the mentor's workplace and meet the mentor's colleagues. This was a really great opportunity for networking and learning opportunity. The other mentors and mentees decided that they wanted to meet each other in DC at the GW Cancer Center offices. They also got to meet Dr. Hall from the School of Public Health at GW, who spoke on implementing, evaluating, and improving communication campaigns. As an output of the mentorship program, mentees also submitted project reports, including a narrative about their process, implementation, and outcomes of their individual communication projects and dissemination efforts. The GW Cancer Center also submitted a report to CDC, the funders of the program, about the successes, challenges, and areas of improvement. The mentorship program curriculum is going to be updated to reflect lessons learned from this cohort, so it is ready for implementation again in the future. Post-program evaluation surveys were created and sent to mentors and mentees electronically to complete late June after the last program meeting. The surveys helped us assess short-term outcomes, namely increased connections to other organizations and professionals, advancement of learning and professional development goals, development of an evidence-based communication project, satisfaction with the relationship between mentors and mentees, and satisfaction with the mentorship program overall. Mentors and mentees were asked to rate these indicators from 1, strongly disagree, and 5, strongly agree. Here are the results. On average, mentors agreed or strongly agreed with the indicators, and mentees were neutral or agreed with the indicators. With a small sample of these 3 mentors and 3 mentees, we can hardly say that these numbers are statistically significant. And one notable factor that may have skewed the results among mentees in particular is that one mentee withdrew a little over halfway through the program due to her organization losing a number of staff and experiencing a funding cut to the Mama Van, which is an integral component of the planned communication campaign. So by the end of the mentorship program, her responses to a lot of these indicators may have been neutral. And so with this caveat, we're pretty pleased with the results. An intermediate outcome of the mentorship program was the actual implementation and some of the evaluation of the communication projects. And as this is a 12-month program and building communication campaigns can often take longer than this, it was expected for mentors and mentees to be at various stages of campaign development. Reedy, who is actually our next speaker, is a mentee who successfully implemented a health communication campaign called Don't Forget the HPV Vaccine that sought to change HPV promotion practices and policies in New Jersey pediatric and family medicine practices. You will hear the process and outcomes of her project shortly. Another long-term outcome for the mentorship program was the dissemination of these outputs. And this webinar is one channel by which we are meeting this outcome. We are also working with Reedy to submit a health communication project as a CDC success story. Mentees were also asked to go one step further beyond completing the post-program survey by completing a core competencies for public health professionals self-assessment developed and adopted by the Council on Linkages between Academia and Public Health Practice, which were compared to the self-assessment they completed prior to being a part of the mentorship program. The assessment is segmented by the shown 8 domains, and mentees were asked to assess their level of competence. 1, for none, or I am unaware that, or have very little knowledge of the skill. 2, for aware, or I have heard of but have limited knowledge or ability to apply the skill. 3, for knowledgeable, or I am comfortable with the knowledge or ability to apply the skill. And 4, for proficient, or I am very comfortable, am an expert, or could teach the skill to others. In the interest of time, I will share results of the primary competency of interest, communication skills. 2 mentees completed this assessment because, as I mentioned earlier, one mentee withdrew from the program due to circumstances beyond our mentee's control. The first column lists the 8 competencies under the communication skill competency domain. The 2 mentees' self-assessment are highlighted in the different shades of blue on the right, and each mentee's pre- and post-program self-assessment scores are listed. Here's the key for self-assessment rating again for your reference. As the yellow row at the bottom indicates, the average score for communication skills increased from 3.3 to 3.6 for one mentee, and from 3.3 to 4.0 for the other. We are pleased to see that mentee 2 went from self-assessing herself as knowledgeable before to proficient in communication skills after the mentorship program. Again, these results are by no means statistically significant, but they show promise for future implementation and possible expansion. So I hope my presentation gave a good overview of the structure and process of the mentorship program. And without further ado, I would like to turn it over to our mentee, Reedy Desai, who implemented a health communication campaign promoting HPV vaccination administration and policies in New Jersey clinics as part of her project in the mentorship program. Reedy is a public health professional and a certified health education specialist. In her previous role, she was a coalition coordinator for Cape Atlantic Coalition for Health, which is a regional chronic disease coalition for Atlantic and Cape May counties in New Jersey. In this role, she coordinated and managed various chronic disease comprehensive cancer control initiatives. Reedy is a native of New Jersey and is a graduate from Rutgers University with a degree in psychology and a minor in public health. Her interests include health communication, behavior psychology, and social marketing. So Reedy, the floor is yours.
Thank you, Kanako. I am super excited to share more information about our projects, especially in context with the mentorship program. So getting started. So before I really start, I wanted to provide some background about our coalition and also the presentation itself. So here are some learning objectives I will be covering. The first one is describing how mentorship actually helped me advance my health communication campaign designed to promote HPV vaccinations to parents and clinicians, and explaining the benefits and challenges of mentorship to advance comprehensive control efforts. So before I start, I really wanted to kind of go over how comprehensive cancer control is structured in New Jersey. Every state is different, and in New Jersey here, we're structured a little bit differently. So the coalitions are initiated by the New Jersey Department of Health, Office of Cancer Control and Prevention. The coalitions were developed in 2004 in each county after a needs assessment was completed for each county. The county coalitions were then charged with enacting the New Jersey Comprehensive Cancer Control Plan at the local level and focused mostly on cancer prevention early detection initiatives. In 2012, the county coalitions were actually merged into regional chronic disease coalitions. So now there are currently 10 regional chronic disease prevention coalitions, and every single county is represented. So the focus still continues on cancer projects to reduce the cancer burden, but it also includes other chronic diseases such as heart disease, diabetes, and also highlights healthy lifestyle behaviors as well. So as you can see, the coalition that I work for, Cape Atlantic Coalition for Health, covers Atlantic and Cape May counties, which are the two most southern counties in the state. Shore Medical Center, which is the community hospital, was the lead agency for this grant, and the coalition is housed actually at the hospital's cancer center. So the mission for the Cape Atlantic Coalition for Health is basically improving health outcomes while reducing the chronic disease burden for the Cape Atlantic region using effective evidence-based strategies and programs. So members are from different areas of healthcare, health departments, hospitals, hospices, and other community organizations. Basically, anyone that has an interest in health or is invested in health in some type of way is welcome to join the coalition. So as you know, I'll be discussing more about the HPV project, but the coalition is also involved in other initiatives as well, such as Body and Soul, oral and skin cancer screening, school wellness, palliative care, health communication, and tobacco efforts. So delving into the problem related to my project, New Jersey has one of the lowest rates for vaccination against HPV. 48% of New Jersey girls from ages 13 to 17 have received at least one or more doses of the HPV vaccination compared to the national average, which is 60%. 35.5% of New Jersey boys from ages 13 to 17 have received at least one or more doses of the HPV vaccination compared to the national average of 42%. So New Jersey is relatively lower when it comes to HPV vaccination rates. So going into the county aspect of it, there really isn't much county-level data available for HPV vaccination. So at this point, this is where I kind of struggled with my project because it was difficult to really find and kind of delve into the scope of the project. So Shore Medical Center luckily has a community needs assessment, and we kind of found some data from that, and we realized that there were over 21,000 females in Cape May County who are eligible for the HPV vaccination, and over almost 72,000 females in Atlantic County were age appropriate for the HPV vaccination. So there's many reasons why parents don't vaccinate, and the most common reason that you usually see is that parents sometimes believe in the myth that vaccination can cause autism. And when it comes to the HPV vaccination, parents are hesitant to vaccinate, especially because it's not mandatory. They don't need it for school. They think it's an extra vaccine. You know, their kid is already getting so many other vaccinations. They're concerned about the safety of the vaccine because they think it's relatively new. And also the media portrayal of vaccination, especially with social media. We're seeing videos and testimonials about different kids or who have had adverse reactions to the vaccine, but in reality those are not true. Religious beliefs, and just kind of scared of the early possibility of sexual activity for the kid. You know, their point is, if my kid isn't having sex, then why do they need it? And that's a big reason when it comes to the HPV vaccination, and the list does go on. So this is an article that I have found when I was developing my project at the beginning of the mentorship program. And this is a great article because it basically, the title just says it all. Doctors, not parents, are the biggest obstacle to the HPV vaccination. So most of the time you always think parents are the problem. But in this case with HPV, it's also the doctors. You know, many doctors feel uncomfortable to talk about the HPV vaccination, especially because they think parents associate the vaccination with sexual activity, and, you know, they just don't want to have that conversation with the parent. And sometimes they just don't have enough time, and it's not mandatory, so why do I need to focus on it? I have to make sure my patient gets all these other mandatory vaccinations. So that brings it more in depth to my project, which is the one solution. Healthcare provider education was really necessary because it helps improve their recommendation to parents and their teens by why it's so important to get the HPV vaccination. And also focusing on quality improvement within the practice. But at the same time, parents are still a key component when it comes to the HPV vaccination. So just trying to find a balance of also just educating parents along the way. Going into the planning and implementation of my project. So what I decided to focus on in my project was focusing on improving healthcare provider recommendation by improving communication skills and reducing missed opportunities for vaccination. Now, because this project was also not only a part of my mentorship program, but it was also part of my grant. So this is actually a mandated project for us from our state to do this project in our counties. So it was a great blend that I was able to learn what I learned from the mentorship program and was able to kind of apply it in reality to a real project that was mandated for us. So it was a nice, great mixture, and the best part was that the original project that we were mandated for didn't really have that much focus on health communication. But through the mentorship program, I was able to add that component to make it more innovative and unique, and especially being able to tailor it for our counties. So here are some project objectives for the project. The first project objective is by May 30th, 2016, educate at least 6 pediatric or family medicine practices about effectively recommending the vaccination by using communication strategies and encouraging the adoption of quality improvement policy through manual outreach. The second objective was to increase 10% of parents in Atlantic and Cape May counties that have been exposed to messages pertaining to HPV vaccine as cancer prevention through health education information at healthcare provider practices. The third, create and develop a healthcare provider toolkit material focusing on strategies increasing HPV vaccination rates. Additionally, create and share a HPV vaccination resource section on the Coalition website for parents and healthcare providers. The next, conduct 2 professional events focused on communication strategies for HPV vaccine for school nurses, physicians, health educators, and social workers. And at least 5 healthcare providers from Atlantic and Cape May counties will use 1 or more communication techniques to create a strong recommendation for HPV vaccine by May 30th, 2016. And finally, increase HPV vaccination immunizations among preteens from 11 to 12 at all 4 offices who adopted a quality improvement policy from 1,934 patients to at least 2,500 patients by December 31st, 2016. So here are the main components of my project. The main focus for my project was focusing on healthcare providers, but also educating parents along the way. So in terms of healthcare providers, the biggest thing that I placed emphasis on was adopting a policy at the practice level to kind of bring the issue out, making sure that everyone in the staff knew that this was important to focus on HPV vaccination. For healthcare providers, I created a provider toolkit and resource guide, and also conducted provider manual outreach at practices, but focusing on communication strategies. Like I said, adopting policy at a practice level, and also offering some continuing education events and webinars to kind of reinforce the ideas that I presented at the manual outreach, and also health education material from themselves, as well as the practices, and also some social media, which included Facebook and Pinterest. For parents, we created a parent resource section on our coalition website, and also created health education material targeting parents and their teens directly at the practices, again, and also engaging in social media. So here is a quick overview of the project timeline. A lot of the components, because this was a mandated grant project, had to be done together. So it is a little bit confusing, but hopefully this will help. From July 2015 to September 2015, this is where we did a lot of our recruitment of the practices. We created our HPV provider toolkit and also distributed it to various practices around our counties. And also planning on creating the educational material and also creating the content for the manual outreach, and also just planning for evaluation. From September 2015 to February 2016, manual outreach was conducted at each practice. There were evaluation follow-up surveys done, health education materials were posted, and also planning for policy implementation, which was the main focus of the program. From November 2015 to December 2015, creation of HPV vaccination posters, and also website material was created and added to our website, and some social media efforts. From January 2016 to May 2016, we conducted professional education for school nurses. We also did a healthcare provider webinar focused on communication strategies, and also more social media efforts. And this is a key thing. From January 2016 to December 2016, this is where the policy piece of the project was implemented in all practices. So for the manual outreach, it was generally 30 minutes long, 20 minutes for information, 10 minutes for discussion. This is very informal. We went directly into the practices during their lunchtime, and we kind of had more of a discussion and focus group rather than more of a lecture. Especially because physicians also are short on time, they're in and out, so we wanted to try to get as many as physicians, nurse practitioners, nurses, office managers in the room and get that information to them quickly. One thing we realized was really important because of that, because of the time limit, was to be concise and to the point, so we can, get their attention fast and, drill them in with these three things. So what I took was I adopted from the GW Cancer Center social media for providers toolkit that they recently did a webinar on regarding the HPV vaccination, and there were 4 key components that I really liked that I adapted from and put into the manual outreach. Was the strength, timeliness, and consistency and urgency. So strength, kind of reinforcing that the strength of the recommendation is very important. They must do it timely, making sure they get their patients that are close to 11 to 12 years old, tell them about the vaccination, get them vaccinated, and also being consistent with your messages, and at the same time telling them that it's really important that they get this vaccination done between this time. And generally at these manual outreaches, we also ask some questions so we can get some feedback so we can further tailor the project and the program better. So messaging, for this, I used meoworks.org. Because it was such a short time period, there wasn't really enough time to create messages from ground zero up. It was more trying to figure out how we can get the best messages out there with low cost, fast timing. So we decided to do meoworks.org, which is a great website where you can create your own posters, postcards, and they have different healthcare topics that you can do. And luckily, they had a category focusing on HPV vaccination. The best part about these posters is that they're already tested. Health literacy is taken into account in terms of the content, which is really great. So we launched 4 posters into each of the practices that we worked with. One is general neutral, as you can see. It takes 3 to protect your child against cancer. And we did a male one. And we also did a female and another male. And we tried to kept it more even, kept it more diverse. And also, this is the front page of the provider toolkit, which I believe is also included in the resources in the pod below. And this was a provider toolkit that was just for the providers. It provided them ideas on how they can implement quality improvement strategies within their practice to improve HPV vaccination rates. Also give them more resources about the topic and other toolkits that are around. This is a snapshot of our website. Basically, like I said, because of lack of time and the lack of resources and also even a little bit of funding, instead of recreating the wheel, we synchronized portions of CDC's information into our website. So this is a parent resource that was taken from CDC's content. And the best part is that it's just a code that you put into your website, and it automatically updates. So the information on this website is constantly updated. It has all the best information on HPV. And also, we put up resources up on the website as well for healthcare providers. This was taken directly from our provider resource guide, and we just put it on the website. And this is a little bit of our snapshot of our social media messaging. This messaging was created on canva.com, which is a great free graphic design website where you can create your own different Facebook posts or timeline covers that we have. So now getting into evaluation. Evaluation was difficult for this project because we worked, like I said, from ground zero up, and we tried compiling resources that we had. And this is, I think, the key component where mentorship really helped me through, because evaluation for me was very tough, especially planning it. So the first 2 objectives was educating at least 6 pediatric and family medicine practices about effectively recommending vaccination by communication strategies and encouraging adoption of quality improvement policy through manual outreach, and also getting at least 5 or more healthcare providers within the counties to use one or more of the techniques that we discussed in our manual outreach. And so how we evaluated this is we did follow-up surveys after the manual outreach. They were sent to all 6 offices. 5 out of 6 offices completed the evaluation. We did think of doing pre-post, but unfortunately that did not work with the format of our manual outreach, especially because when physicians are in and out, it's very difficult to get them to do a pre and post test. So we did find that 60% of the practices that took the survey believed that the educational meeting or workshop provided my practice with relevant information and strategies that can help my practice effectively recommend the HPV vaccine and improve our HPV vaccination rates. 60% believed that they shared the information that was received with their staff to some extent. 40 and 60% mentioned that they used any of the strategies discussed in the meeting or workshop to a greater extent to some extent, respectively. We did create our healthcare provider toolkit, so that has been completed, and we also created and shared a HPV vaccination resource section on our website for both parents and healthcare providers. We also conducted 2 professional events focusing on communication strategies for school nurses and physicians and health educators and social workers. So we held 2 different events. One was an in-person event focusing on the prevention of HPV vaccination for girls and boys. This was more targeted towards school nurses, but we did offer continuing education credits for both programs. Sorry. And the first one was actually held on Tuesday, January 19th from 5 to 7 p.m. at our facility at Shore Medical Center. And the speaker was Dr. David Walsher from Cooper University Hospital. So we had 38 people register for the conference, 19 people attended, and 9 of them were school nurses. For our second professional event, we did a webinar in partnership with the Ocean Mammoth Health Alliance, which was another regional chronic disease coalition. And we also collaborated with the New Jersey Immunization Network, and we conducted this webinar on Monday, March 21st from 12 to 1 p.m. The speaker was Dr. Margaret Fisher. We had over 143 individuals register for the webinar, and about 93 people attended. And similar to the in-person event, we offered continuing education credits to nurses, health educators, and social workers, and this time we were able to also have CMEs available for physicians. So finally, the main component was the policy piece, like I mentioned before. And one of the pediatric practices that we worked with were Rainbow Pediatrics. So they started their policy from January 2nd, 2016. And they decided to kind of not only focus on kids from 11 to 12, but also include the process from 9 to 18. So they decided to use the electronic media record, and that would prompt the physician for any wellness visits starting at age 9 to kind of prime the parents and the teens about the vaccination, give them more information. And when they're around 11, they would have an automatic request directly in their EMR prompting the physician to recommend the vaccination. And they would also make sure to bundle the vaccination with MVC4, Tdap, and HPV together. So this is, it makes it more easier for the parent. They're like, oh, it's one more vaccination, no big deal. And we also worked with Wildwood Medical Associates. So Wildwood decided that at every single wellness visit, if eligible patients come in with their parents and caregivers, they would give them information about the HPV vaccine. And the provider will then educate the parents and caregivers about the information about the vaccine and make sure to answer any questions. Again, then the provider will strongly recommend the vaccination in the exam room. So this was a big win for us because we were able to get practices to actually have written policies in terms of how to recommend this vaccination. So this is the baseline data. So what we did is at first we did baseline data in January, and then we did mid-year data, which is July 2016, and we'll get the final data in December 2016. Rainbow Pediatrics has 3 different offices, and almost 28% of all patients received the vaccination at their Cape May courthouse, which is 548 received the vaccine out of 1,933 patients, and Egg Harbor Township, 24% of patients received the vaccination, so that's 401 out of 1,689 patients. In Rio Grande, 39% of patients received the vaccination, and 896 received the vaccine out of 2,310 patients. At Wildwood Medical Associates, which is a smaller practice, about 89 patients between the ages of 11 to 12 have received the vaccination. So this is the mid-year data that which was received in July 2016. And overall, for all the practices, especially for Rainbow, there was a 2.3% HPV vaccination increase for Rainbow Pediatrics. So overall, they increased 2.3% of their vaccination overall. Unfortunately, for Wildwood Medical Associates, there was no data received. I actually moved on from this position, so I was not able to directly work with them to get the data and to make sure that the data was updated and we got on time. So there has been some complications in getting the data. So planned evaluation, basically, we'll be getting more HPV vaccination rates in December 2000 and, well, for the entire year, and the data will be sent out in January 2017. There will be an end-of-project survey, and we'd also do kind of calculate the number of health education materials and how many parents or teens that they reached. So success was really for this project was the main thing was getting those office policies adopted. This was a pilot project. It was a new project also for the coalition as well as for me. So that it was just great to be able to have these practices adopt written policies. And also just getting the discussion started. A lot of practices and doctors, they think they recommend it, so they don't realize that, they don't recommend it effectively. And also creating communication materials, being able to educate all 6 practices. And, the best part was just kind of go into the offices and talk to the providers directly and learn more about their experiences with vaccination. That was very insightful. And the best part was coalition members. The coalition, even though they were from different agencies, if they were engaging in the intended audiences, which was healthcare providers or, parents, they would take their information and share them, wherever they went, which was great. But there were definitely challenges. Like I said, this was a new project for us. It was our first year doing this project, and it was mandated by the Department of Health, the Office of Cancer Control Prevention. But we didn't really receive any resources or foundation for the project, so we kind of went in kind of blind in a sense, and we actually create everything from the ground up. And the lack of partners locally, even though we have a big coalition, a lot of the coalition members did not really work on vaccination, so it was very difficult to find partners to work on this with us directly. And also time. With other grant projects, there was always lack of time. And also check the box mentality. We did offer our practices a stipend for participation, and we noticed that some just, wanted to get it over with sometimes, especially with the manual outreach. And also lack of recognition of coalition. Since even though we are associated with the hospital, this is a coalition project, and we didn't want to have a conflict because we were associated with the hospital. So a lot of practices, a lot of doctors didn't really recognize our coalition because it's considered to be outside organization. And evaluation, I think, was really the toughest. It was very difficult on trying to get evaluation done and making sure the practices were really comfortable with evaluation. And getting them on board. A lot of the time spent on this project was recruitment, trying to convince them to get onto this project because practices are very busy. They're dealing with staff, they're dealing with time, and to get one thing on their plate, it's very difficult. But eventually, with lots of pushing and nice pushing, I guess, we were able to get some practices on board. Lessons learned. One thing I really learned is that concise messaging is really important, especially when you're targeting healthcare providers. And it's really important to make material simple and to the point. Evaluation needs to be more direct, more easier, and just researching and tailoring accordingly to the practices. Each practice is different, so that has to be really put in account. And strong partners can really make a big difference. If I had more partners involved with me in this project, if we had more local support, I think it would have been even bigger, which would have been great. So this kind of brings on to the main point of the presentation is why mentorship. Mentorship has been really useful for me. And the benefits of mentorship are endless. Professionally, I really learned a lot from my mentor, Dawn Swindle. I can't gush about how awesome she is. And not only was I really able to successfully implement a project with her guidance, I was actually able to learn from her past experience. And experience is really the key in public health. Even though I had some knowledge of health communication, Dawn really helped me understand communication on a general level. And communication is such a big field. It's confusing, especially for one that's been only working in public health and has some knowledge of health communication. I was able to ask her any questions, share any ideas, whether through email or during our monthly calls. One thing I wish was that she was a little bit closer, because I would love to get coffee with her like every single week and have conversations about everything, including health communication. And since Dawn has been really involved in the HPV effort in Indiana, she was really able to share some advice and stories from her own project, which really helped develop mine. And one example I can give is that for the school nurses, I know Indiana Cancer Consortium conducted school nurse webinars. And for our second professional event, that's how I got the idea to do a webinar, but not only include school nurses, but also include healthcare providers. And she was always helpful in, connecting me with different individuals in the field for resources for my project. Always ready to give me an introduction to someone she knew in the field. And she was kind of always, I think, my tester. If I created something new, I always would send it to her, especially the posters and toolkits, and she would give me honest advice, what she thought about them, and that was just really helpful. And just finally, a lifelong friend, someone I could always kind of connect with, even if I have an issue in the future. So it's just been really great working with Dawn in the past year, and I've learned a lot. And thank you, Dawn.
Thank you, Reedy. I wanted to point out a few things about resources, as well as a question that we were asked on Make It Your Own. But before we do that, does anybody have any questions for either Kaneko or Reedy? If so, just let us know what your name is and then ask your question, or type it in the chat box. In the meantime, just to remind you, if you look on at the bottom left of your screen, you will see a bunch of resources, including the communication guide or media planning template, as well as a few resources on HPV that you can, as well as the webinar slides. And as I said, we'll be emailing you the information, some of the information, if you don't want to download everything. As far as Make It Your Own, we provided the link for you. Reedy, do you want to talk a little bit about how to use it? We have just a little bit, just a couple of minutes, if you want to go over that a little bit.
Sure. So with MeoWorks, do you think I can get a link open or anything?
Yes. Let's see.
I think that would be easier for me to explain. Sorry.
Absolutely. Let me see if we can do a screen share, but 1 minute. We're gonna let me see if I can get this done. Yeah, I tried to do it, but I don't have the plugin on it, so that might be something to explore later. But definitely, the link is provided for everyone. It's pretty, user-friendly, but I was hoping that you would be able to kind of go over it a little bit. I don't know that I can get it to share.
I can briefly describe it though. So
yeah.
MeoWorks, basically you just need to log on, you create a sign up, and there's different topics right now. They have limited topics. They have HPV vaccination, they have promoting breast cancer screening, promoting cervical cancer screening, also promoting quit lines, I believe. So the HPV vaccination they've recently added. So when you go in, you have options to choose whether you want to create a flyer, a postcard, or a poster, or an insert. And they have designs already pre-done, so you can select the design you want. And when you do select that, you select the graphic. So they have graphics already built into the website that you can use for free, which is great. So you can choose the image, and you can also kind of, I guess, tear it down to your main target population. So if you're focusing on, if you're targeting African American girl, you can have that you can choose that. You can choose, they have different messages that you can choose. And they have reading levels attached. So you can choose what reading level you want to go with. And they basically walk you through, the website itself walks you through the entire process.
Great. Thank you. That's a great brief description considering our limited time, and I'm sure people can definitely go through it as well and do, email, you have a contact information. Feel free to email if you have any questions. Kanako wanted to chime in a little bit.
Yeah, so I just wanted to add to Reedy's description of MioWorks. MioWorks is a great platform that uses and aggregates a lot of the already tested evidence-based messages. So you do not have to start from scratch, although you may want to do a little bit more digging and research to tailor it to your specific community. MioWorks has done a great job of giving you a general list of communication tactics and messages that you can choose from. And as Reedy mentioned, that you can choose from a number of photos and images to put on your poster or brochure or whatever medium you are creating. So I think MioWorks will be a great first step to look into some free options to create your communication material.
And while I wrap up our webinar and some closing remarks, please take a few moments now to complete our session evaluation polls that are up on your screens. We take your feedback seriously and incorporate your suggestions to continuously improve our events. I'd like to extend a huge thank you to Kanako and Reedy for their fantastic presentations and discussions. I'd like to also thank all of you for participating in the webinar today and for sharing your questions, thoughts, and experiences. If you have any, I think we got just a couple of comments online, but feel free to definitely follow up, and we provided the contact information. I hope you found today's meeting informative, and we encourage you to stay in touch and continue this conversation as you work on your communication projects, whether they're on HPV or any other cancer risk factors. We're always keen to disseminate best and promising practices and the innovative work we know you're doing. Finally, please check our comprehensive cancer control technical assistance website, the cancercontroltab.org, to access more resources and professional development opportunities. Thanks again, everyone, and we hope to see you or hear from you soon.